Hi guys, Dr Daniel Nightingale here, your clinical dementia specialist. I hope you're having a great day. I certainly am. And today I wanted to talk about something that is probably a very sensitive subject for most people. And it's about intimate relationships when people are living with a neurocognitive disorder such as Alzheimer's disease. They live at home with their husband or wife or partner, and intimate relationships. How do we deal with that? How does that work? How does that pan out? Well, there's a few different things here. One is the normal relationship, and maybe that doesn't change. Maybe the normal platonic and intimate relationship doesn't change. So you carry on as normal. Sometimes it does. And it's when it does change that we might start having some behavioural issues. So in the video that was posted on my YouTube channel yesterday, we talked about the sound relationship house and how to maintain a healthy relationship. So today I wanted to take that a little bit further and talk about the intimate aspect of it. It is quite a sensitive subject. People kind of skirt around it, but I come across these challenges, these issues in my practice. So the normal stuff is okay, it doesn't change, everything carries on as normal and everybody's happy. But sometimes it does change. And let's think about a type of dementia that can lead to somebody becoming hypersexual and behaving in an inappropriate way because their inhibitions have been removed, there's nothing to hold them back from their behaviour, and it's quite possibly going to be a behaviour that is unwanted. So the dementia that I'm thinking about here is a frontal temporal dementia, but the behavioural variant. Not everybody with frontal temporal dementia will have these challenges, but if they develop the behavioural variant, that is when the inhibitions are gone away. So that is when we might start seeing the challenges. We might start seeing inappropriate sexual behaviour in different places, in inappropriate places, in public places and things like that. So what do we do about that? How can we manage that? How can we mitigate it, ameliorate it, reduce the risk from that happening? And really it's all about structure, and it's about understanding, and it's about ensuring that you've got this approach and this intervention that is proactive. You know, we're very often reactive, aren't we? Well, we've talked often in videos about being proactive and about supporting individuals and not using medication as a first resort. Use it as a last resort. Use it as part of a holistic approach to supporting that person. So very often what I find is if somebody has a structured day and they have things to focus on and concentrate on and things to achieve, little goals that are set so that they can achieve those goals. It might just be baking a cake or making a pie or doing a model, building a model aeroplane or doing a jigsaw puzzle, or whatever it is that has some focus and concentration that takes that person away from unwanted behaviour to more constructive behaviour. So that's the first thing to think about. Having a structure, having something to focus on, having something for that person to really achieve. Okay. The other thing is about, we can use cognitive behaviour therapy to help mitigate some of that behaviour. But remember, what we're dealing with here is a lack of inhibition, and we can't create that. We can't inject that back into the person's thought processes or the brain pathology or the mind. It's gone. So we have to understand that, and we have to acknowledge that, and we have to work with that in the best possible way that we can. So this is when people become hypersexual, and of course hyper meaning over sexual. So you've got to think about having that structured approach. The other thing is we can use cognitive behaviour therapy for changing people's thought processes, And there's also something that we can use called rational emotive behavior therapy, which is very similar, but it was developed by somebody else. You know, Aaron Beck created and developed and introduced cognitive behavior therapy. Albert Ellis introduced rational emotive behavior therapy. They're both quite similar, but there are some differences. But we can use that as a form of therapy to help manage some of that unwanted behavior. And again, what we're trying to do is change people's thought processes and see if we can get people to really focus on something that is constructive as opposed to it being destructive. Okay. There has been some use and some success by using the SSRI drug, antidepressant drug called paroxetine. So there has been some success with that, with helping manage the the anxiety that people may have and the hypersexual side of things. So in a nutshell, what we need to be doing is developing an intervention, an approach that is proactive, that reduces the risk of somebody becoming hypersexual or at least expressing hypersexual behavior. Because again, remember, the inhibitions, can't replace them. If they've gone, we have to find alternative approaches and interventions. It's always a good idea, and I explained this in a video previously about monitoring somebody's behavior. Because if you're going to come and see me, or you're going to go and see a doctor, a psychiatrist, a neuro, whoever you might be going to see, take some data of when did this behavior occur? What time? Where were you?
Was there a trigger?
Was there a trigger? And all those kind of things, you know, the things that we talked about I think it was last week, we talked about the antecedent behavior and consequence monitoring for behavioral issues. So it might be a good idea to use that ABC chart that is out there on the video from last week. I believe it was last week. So what I don't want people to think about is this is disgusting behavior. People might start masturbating out in public. I don't want people to think this is disgusting behavior. I want people to understand that this is because their inhibitions have gone. The things that stop the majority of people from doing that, there isn't the mechanism there to do that anymore. And it might not come to that. It might not be hypersexual behavior. It could be swearing, using language that people had never used before, and they would never even think about using those terms and that kind of language. But it's because of the inhibitions not being there anymore. So think about it as, okay, this is a challenge, but this is a challenge for everyone. It's not that individual's fault. We're not going to blame that individual. We're not going to take them away and put them in a behavioural health unit and pump them full of drugs and things like that. We're going to look at it and say, okay, what can we do holistically to help manage that behaviour that improves quality of life, excuse me, that improves quality of life for the individual and for the spouse or the partner, okay? So if you have any questions about that, please email me, Dr Dan at drdanielnightingale.com, or contact me through YouTube, this channel, or Instagram, or Facebook. You can find me on all those platforms. And I believe somebody does have a question.
Yes. Maybe this is a subject for another video, but since we're talking about intimate relations between people, what about when people have difficulty because of medications they're taking, and so they're not able to have the type of sexual relationship they once enjoyed, but it's because of the drug side effects or the dementia side effects or something like that?
Yeah. Well, then you need to take that up with whoever is prescribing those medications. And if it's your primary care doctor or your primary physician or your neurologist or whoever it might be, it's about talking to them about that issue. There are some medications, of course, that do prevent men from getting an erection or to prevent women from arousal. but they're very unusual.
Or
side
decreased
effects.
libido.
Yeah, they're very, very unusual side effects. And I think the issue here, Lynn, is that we're dealing with a diminishment of inhibition. So medication, whatever medication, wouldn't change that.
Right.
But when it comes to sexual function, then that can possibly be changed if it is a side effect of medication. Sometimes it is, sometimes it isn't. And a good person to talk to is, of course, the urologist, because urologists are trained to understand and work with that side of things.
So some of the common drugs that are prescribed to people with neurocognitive disorders are donepezil and memantine and maybe some antidepressants or other things. Do any of those commonly cause issues with sexual function or libido?
Typically, your anti-dementia drugs, such as you mentioned, Aricept, which is also called donepezil, or galantamine, or rivastigmine, or memantine, Ibixa, they tend not to have that side effect. It's always a possibility, but it's not a glaringly obvious side effect of those medicines. The monoclonal antibody infusions, such as lecanemab, similar kind of thing. There's no reason why it should impact on people's sexual function. Okay, but it may happen.
Okay. Thank you.
Yeah. So just to recap that, understand the diminishment of the inhibitions is the reason for a hypersexual or hyperarousal behavior. So manage it from that point of view. Use a holistic approach, use a proactive approach of ensuring somebody has something to focus on and something to achieve and a goal. And if the doctor who is caring for that individual thinks a paroxetine might be a good idea, then that's okay, as long as it's part of the holistic approach and not just a standalone prescribed medication and nothing else happening. So that's what I wanted to talk about today. I hope you all have a fantastic week. The sun's shining where I am today. I hope the sun's shining in your life too. Thank you for listening to my video. And remember, guys, say it with me, dump the soda.